Receiving adequate oxygen is crucial, especially after a serious injury, illness, or cardiac arrest. You can decrease patient stress and support the respiratory system by administering emergency oxygen to someone in need. There are many types of oxygen units available for emergency care. Some are simple to set up, while others are more complex. Become familiar with emergency oxygen units you might use before you need to use them. Oxygen is safe to use, however, there are a couple of precautions. First, handle emergency oxygen in well-ventilated areas away from any source of flame or heat. Also, handle oxygen cylinders carefully, since their contents are under high pressure. Avoid dropping the cylinder or exposing it to heat. To begin using emergency oxygen once the unit is assembled, first turn the valve on slowly. When providing emergency oxygen to a responsive patient, say, "This is oxygen, it may help you." Next, you take the first breath to show the patient that the mask is working. Now, place the mask on the patient and have them hold it in place. Tell the patient just to breathe normally. You may also use the strap to secure the mask on the face of an unresponsive breathing patient. For an unconscious, non-breathing patient, use a mask that allows you to supply rescue breaths while oxygen is flowing. As you use the oxygen unit, monitor its pressure gauge to avoid running empty while the mask is still on the patient.
Marty, are you okay? Marty!
Are you choking? I'm an emergency responder. May I help you? All right, take it easy.
Wait a minute. Do you need help?
Hey, Kevin, are you all right?
Jimmy, come here quick!
Susie, go call for help.
My neighbor just collapsed. Can you please send someone over?
My name is Eileen. I'm an emergency responder. May I help you?
Are you okay?
Medical emergencies and accidents happen every day.
Hey, Susie, can you call for help? Bring a first aid kit. Kevin, it's Steve.
At home, while commuting, at work, and during recreation. They're an unfortunate but inevitable part of life. Usually the first person to help is a layperson, friend, co-worker, or passerby. Someone like you. There are no guarantees, of course, but by applying some basic knowledge and skills as an emergency responder, you can do everything reasonably possible to produce a favorable outcome for the patient. You learn these basic skills in the Emergency First Response Primary Care, CPR, and Secondary Care, First Aid courses. Emergency First Response Primary Care, CPR, prepares you to aid patients with life-threatening emergencies. You learn the same emergency care priorities medical professionals use. Emergency First Response Secondary Care, First Aid, builds upon what you learn in the Primary Care course. In that course, you learn to give aid for medical emergencies that aren't immediately life-threatening. Emergency First Response Primary Care, CPR, and Secondary Care, First Aid courses follow emergency considerations and protocols as developed by the various members of ILCOR, the International Liaison Committee on Resuscitation. Although Emergency First Response is an internationally based course, local variation in skill technique, first aid procedures, terminology, requirements, and course flow may exist. Your Emergency First Response instructor will guide you. In Emergency First Response Primary Care, CPR, you learn 9 essential skills that link together when you help someone in a life-threatening emergency. Skill 1. scene assessment. Skill 2, barrier use. Skill 3, primary assessment. Skill 4, CPR chest compressions. Skill 5, CPR chest compressions combined with rescue breathing. Skill 6, serious bleeding management. Skill 7, shock management. Skill 8, spinal injury management. And Skill 9, conscious and unconscious choking adult. You may also learn other optional primary care skills, such as automated external defibrillator use and emergency oxygen use. In emergency first response secondary care, first aid, you learn what to do when emergency medical services, EMS, are either delayed or unavailable. Secondary care skills include Skill 1, injury assessment. Skill 2, illness assessment. Skill 3, bandaging. And Skill 4, splinting for dislocations and fractures. This video covers the skills for both courses. After watching the skills demonstrated in the video, your instructor will have you practice the skills. After you've learned to perform and sequence the skills, you'll get to practice them in simulated emergency situations. This teaches you to adapt your emergency responder skills to real emergencies.
Are you okay?
A medical emergency arises. As an emergency responder, you know that if you assist, you can save or restore a patient's life. You can reduce a patient's recovery time. And you can make the difference between a temporary or lifelong disability. Even knowing this, sometimes people hesitate to help. Even people with CPR and first aid training. They may feel anxiety or guilt about the situation. Sometimes they're afraid they'll do the wrong thing. They fear imperfect performance or making a person worse. In some societies, people are afraid they'll get sued if the situation doesn't work out right, and there's the fear of communicable diseases. As an emergency responder, realize that none of these concerns need prevent you from helping in a medical emergency. Let's look at why. First, let's look at the fear of infection. You may hesitate because you are afraid of being infected by the person you are assisting. This is a concern, but remember your training includes learning to use protective barriers to minimize the risk of disease transmission. By using barriers, you're highly unlikely to get any disease or infection from someone you help. Second, focus on helping, not perfection. You want to do the best you can, but it's unlikely a minor error will make much difference, much less hurt or kill a patient. Focusing on perfection tends to make people hesitate in a real emergency. Do not hesitate. Help. Remember, adequate care provided is better than perfect care withheld. Third, learn to trust your training. During the scenarios, you'll find that what you think you forgot comes back when you provide aid. At first, things feel awkward. Then suddenly you've got it, like getting back on a bicycle after not riding one for years. Remember this feeling. You can trust it in a real emergency. Fourth, be decisive and act. Usually there's more than one right way to handle a situation. Circumstances don't always provide clear direction. Start helping immediately. To help you be decisive and act, Emergency First Response has developed an easy-to-use prompt to remind you of the important steps needed to assist someone in need. The Emergency Care at a Glance Decision Guide provides you with comprehensive primary and secondary care directions. This is a must-have addition to your first aid kit at home and on the road. Fifth, you may be concerned about your responsibility when helping another in need. You may hesitate because you're afraid of being sued. In general, the fear of being sued should not stop you from providing emergency care. Many countries have Good Samaritan laws which simply say that as a layperson helping another, you cannot be successfully sued if ultimately things don't work out well for the patient. Your training in this course will show you how to provide help within the protection of these laws. Good Samaritan laws will generally protect you if you provide care within the scope of your training as an emergency responder. Ask for permission to help. Act in good faith. Are not reckless or negligent. Act as a reasonably prudent person would. And don't abandon the patient once you begin care. The exception is if you must do so to protect yourself from imminent danger. Finally, don't worry about making a person worse. The most serious medical emergency is when a patient is unresponsive and isn't breathing normally. Sometimes people hesitate to help such a patient, fearing they'd make him worse. As an emergency responder, realize that you cannot make such a person worse. A person who is unresponsive and isn't breathing normally is already in the worst state of health.
Hey, I need some help here.
Again, remember you cannot make the person worse, but you may be able to help this person.
Call for help and bring an AED. Okay. He's not breathing.
You don't need to fear providing rescue breaths and chest compressions. You can trust your training. Take a moment to relax, think of your training, then step forward and help. CPR, cardiopulmonary resuscitation, helps to oxygenate the body when the heart isn't beating. You do this because if CPR begins soon enough and if emergency care arrives quickly, then it may be possible to restart the patient's heart. CPR won't usually restart the patient's heart. Instead, it extends the period during which it may be possible to restart the heart.
Take it. Todd.
Realize that CPR doesn't guarantee that the patient's heart will restart. In fact, most of the time, even with CPR, it doesn't restart. This means that you can never know whether providing CPR or any other aid that's called for would have made a difference unless you step forward and provide help. If you provide CPR and the patient's heart doesn't restart when medical care arrives, realize that you did everything humanly possible. But if you could have provided CPR and didn't, you may spend the rest of your life wondering whether it would have made a difference. Don't let that happen. Trust your training and help. Remember, adequate care provided is better than perfect care withheld.
One of the things that I want to emphasize is we're here.
While you are taking this course, don't be intimidated. Naturally, you'll make mistakes during the course. It's a normal part of learning. So if you make one, just adjust and try again. You'll have plenty of time to practice, build your confidence, and be ready to help someone in an emergency.
Perfect.
Also, have fun. That may sound odd considering the seriousness of what you're learning, but you'll learn more and learn faster when you enjoy the learning process. Keep it light.
Very good.
Your ability to use a skill effectively weakens when you don't use it for a while, but once you've learned it, it comes back much easier than learning it the first time. The more recently you've practiced a skill, the easier it comes back. The same is true for your emergency first response skills. Hopefully you won't need them often in real emergencies, so you want to practice to keep them fresh. Here's how. First, watch this video from time to time so you remember the skill steps and the information that relates to using them. Second, run through practice emergencies with other emergency responders in your family or among your friends. Try to get some CPR practice. If you don't have a CPR mannequin, use a stuffed sack that's the right size or even a pillow, but never practice CPR chest compressions on a person. Doing so can interfere with the person's normal heartbeat. Finally, refresh your skills with an instructor in the Emergency First Response Primary Care, CPR, and Secondary Care, First Aid refresher course at least every 12 to 24 months. When you complete the update, you'll receive a current Emergency First Response completion card. When you recognize a potentially life-threatening emergency, you help with the first 3 links in the chain of survival. Link 1 is early recognition and call for help. Link 2 represents early CPR. The third link is early defibrillation. The fourth link, early professional care and follow-up, is for professional healthcare providers. In a life-threatening emergency, early professional care is very important. The sooner emergency medical professionals arrive, the better the outlook for the patient. The emergency responder does not replace professional emergency medical care. In the chain of survival, your role as the emergency responder is to summon emergency medical aid and to assist the patient until it arrives. Activating EMS is so important that in most circumstances, if you're alone and there's no one else to activate the EMS for you, you call first, then assist the patient. An exception to the call first rule is if the patient is a child or an adult who has experienced submersion in water. In these cases, you provide CPR for a short time, particularly rescue breaths to the patient, and then call EMS. This is called care first rather than call first. The various resuscitation councils define providing CPR for a short time differently. Some define a short time as providing a minute of care, and then some define it as 2 minutes. Your instructor will guide you. With EMS on the way, the care you provide increases the chance that advanced care will help the patient when it arrives. Your training in this course is based on handling emergencies where you have an emergency medical system. If you need to provide emergency aid in areas away from EMS support, you should continue your education with more advanced first aid training. Providing emergency care can be very stressful. After the incident and after the emergency medical professionals take over, it's time to take care of yourself. You may wish to talk about the event to a friend or family member. You may find the situation upsetting, especially if things didn't work out well for the patient.
Still, I feel like I let him down. I mean, what about his family? I feel like I let them down too.
Talk to someone if it helps, including a healthcare professional if necessary. But remember that as an emergency responder, your training only gives those you help the best chances possible, not promises nor guarantees of medical miracles. No matter how it works out for the patient, feel good about the fact that you reached out to help another.
All right. Maybe you're right. Maybe doing something is better.
Before helping someone, it's important to ask for permission to help. You do this with the responder statement.
Okay, I'm an emergency responder. May I help you?
Yes, please.
You simply say, "Hello, my name is," your name. "I'm an emergency responder. May I help you?" It's important to get the patient's agreement if he is alert and responsive. If a patient is unresponsive, give the responder statement anyway.
My name is Christopher. I'm an emergency responder. May I help you? Are you okay? Are you okay?
If the patient can't answer, most laws assume implied consent. This means the law recognizes that in a serious situation, the patient would almost certainly want help.
I have an emergency. I have a man down.
Laws vary from one region to the next, so check those that apply to you.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
If an adult refuses your help, don't force it on her. Instead, talk to the person, stressing the need for care and monitor her condition without providing actual aid. Depending on the situation, however, you could activate EMS at this time. Have you ever wondered how medical professionals know what to treat first when they help someone? They use a cycle of care to sequence treatment and monitor a patient's medical status. Using the memory word ABCABS, the cycle of care speaks directly to a pathway of priorities for emergency care. By learning the memory word ABCABS, you'll know what to do first, second, third, and so on when a person with a life-threatening illness or injury needs your assistance. You'll practice using the memory word ABCABS in a cycle of care as you learn emergency first response skills. The meaning of the memory word ABCABS is as follows. Within the AB portion of the memory word, the first A in ABCABS stands for airway. Essentially, the A reminds you to ask the question, is the patient's airway open? Also, within the AB portion of the memory word, the first B in ABCABS stands for breathing. This letter reminds you to ask the question, is the patient breathing normally? In the cycle of care, you begin by initiating a very quick check of the patient, attempting to answer these two questions. Is the patient's airway open, and is he breathing normally? If the patient's airway is open, but he's not breathing normally, then you call emergency medical services and quickly move into the cycle of care.
1, 2, 3, 4, 5, 6, 8, 9.
Within the memory word ABCABS, the CAB portion of the word reminds you how to perform CPR. Let's see how. CAB stands for chest compressions, airway open, and breathing for the patient. When a patient's not breathing normally, you must act immediately to provide chest compressions.
7, 8, 9, 10, 11, 12, 13, 14, 15, 16,
After chest compressions, you open the patient's airway and then breathe for the patient. As defined earlier, this is how CPR is administered. After breathing for the patient, you continue to move through the cycle of care by returning back to chest compressions, opening the airway, and breathing for the patient. You continue with the cycle of care until professional help or an automated external defibrillator, AED, arrives. More on AEDs later. If the patient is breathing normally, you move along the cycle of care to the S portion of CABS. The S in CABS reminds you to look for and treat serious bleeding, shock, and spinal injury. In this course, you'll learn how to manage each of these medical emergencies. When you come across a possible medical emergency, what's the first thing you do? It may surprise you that the first thing you do is think about yourself. You need to protect yourself. This is for the sake of the person needing help as well as for yours. After all, if you get hurt, you can't help. Assessing a scene is the process of looking for and avoiding any dangers at the scene of a medical emergency. It's the first thing you do and the first skill you'll practice. Scene assessment takes 3 steps. 1. Stop. 2. Think. And then 3. Act. Stop and assess the scene for hazards. Ask yourself, what caused the injury? Are there any hazards? Look for potential hazards such as leaking gas, chemicals, radiation, downed electrical lines, fire, firearms, the possibility of explosion, or oxygen depletion. Can you make a safe approach? Consider how to make a safe approach. Be alert for possible dangers, such as oncoming traffic. Do you need to turn off a car's engine? Apply barriers as appropriate and if available. Next, think. Formulate a safe action plan. Can you remain safe while helping? Remember that your safety must be the first priority. Know your limitations. What emergency care may be needed? How can you activate local emergency medical services? Can you locate an AED? Can you have bystanders activate emergency medical services or locate an AED? Think about your training and relax. Now act. Begin providing care. To act, follow the emergency care guidelines you will learn in this course. As you help, follow the emergency first response skill sequence of priorities. But scene assessment and taking care of yourself never stops. Ensure your safety so you can help others in need. Earlier, you learned that some people fear infection and therefore hesitate to help others in medical emergencies. The diseases of most concern are those transmitted through blood and other body fluids. These are hepatitis B and C and the human immunodeficiency virus, or HIV. As an emergency responder, you can greatly reduce infection risk by applying barriers. Barriers include gloves, ventilation shields, ventilation masks, face masks, and eye shields. Gloves and ventilation shields or masks are useful during CPR. Gloves, face masks, and eye shields are useful barriers when exposed to body fluids such as blood. As important as they are, however, do not delay emergency patient care if barriers are not available. Research has shown that the chance of disease transmission is very rare when providing CPR. Nevertheless, you can minimize the risk of infection by always placing a barrier between you and the body fluids of the injured or ill person. Like scene assessment, barrier use is a skill that usually comes before you start helping the patient. Remember to begin with Skill 1, scene assessment. Stop, think, and then act. As you are assessing the scene, put on gloves if you have them. Put the gloves on carefully to avoid tearing. Removing your gloves once you have finished treating a patient is a bit more involved. Your objective is to remove them so that you don't spray or spread body fluids. To remove the first soiled glove, carefully pinch the outside portion of the glove at the wrist, like this. Next, gently roll the glove off so that the outside portion is turned inside. Hold the removed glove with the gloved hand, like this. To remove the remaining glove, place the ungloved hand under the glove at the wrist, next to the skin, and roll off in the same manner. To finish, roll this second glove off and around the previously removed glove, like this. Finally, place the gloves in a biohazard bag for disposal according to local guidelines. Your instructor will show you how to use one or more of the different ventilation shields or masks available. These barriers trap or isolate you from moisture or fluids from the patient's breath and mouth during the rescue breathing step of CPR. Barriers take up little room, so it's easy to keep a set handy at all times. But remember, the chance of disease transmission is very rare when providing CPR. The risk of infection may be even lower if you're helping someone who has a medical history you know, like a family member. Therefore, you may not need to withhold aid just because you don't have a barrier. You've assessed the scene, and perhaps you've applied your barriers. Now you're ready to begin primary assessment. Primary means first in a series or sequence. Assessment is an evaluation or an appraisal. Primary assessment helps you recognize life-threatening conditions and prepares you to provide priority emergency care. By conducting a primary assessment, you will be able to answer the questions: is the airway open? And is the patient breathing normally? This is the AB portion of the ABCABS memory word. After you conduct a primary assessment, you proceed immediately to attend to any life-threatening conditions you discover. No matter what the patient's situation when you arrive, you begin with a primary assessment. Primary assessments all follow the cycle of care sequence that speaks directly to a pathway of priorities for emergency care. Throughout an incident, you continually monitor the patient and use the cycle of care to guide you, ready to provide assistance based on what you learn from your assessment. Watch this emergency scenario, noting how the cycle of care guides the rescuer. After the scenario, we'll review how the rescuer applied each step.
Hello? Ricky? 7. I'm an emergency responder. May I help you? Ricky? Ricky, are you okay? You okay? Yeah, my friend just collapsed. He's not breathing and he's unresponsive. 3234 Tomas Street. Yes. Thanks. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30. One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15,
The cycle of care answers all questions about what injuries or illnesses to treat first. For instance, suppose a patient has serious bleeding and doesn't appear to be breathing normally and is unresponsive. What do you do first? Easy. The cycle of care guides you. First, you assess the scene. Make sure it's safe for you to approach the person in need. Then quickly, seek answers to the questions. Is the patient's airway open? Is he breathing normally? To do this, first open the patient's airway and then quickly check for normal breathing. This patient isn't responsive or breathing normally, so if you're alone, you need to call emergency medical services. Next, immediately begin chest compressions.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
After giving chest compressions, open the patient's airway and begin breathing for the patient. Chest compressions and rescue breaths, CPR, takes priority over serious bleeding. ABCABS and the cycle of care correctly leads you through the priorities of care. In this scenario, you deal with the fact that the patient is unresponsive and is not breathing normally before you treat his serious bleeding. If the patient begins to breathe normally and becomes responsive, then you can attend to his serious bleeding. Let's look at primary assessment, first with a responsive patient and then with an unresponsive patient. A responsive patient is one who is alert and able to answer questions. Begin with assessing the scene. Stop, think, then act. Next, give the responder statement. Hello, my name is, your name. I'm an emergency responder. May I help you? Because responsive patients are talking or making noises other than gasping, you've verified that their airway is open and they are breathing normally, the first two steps in the cycle of care. This patient is responsive and is breathing normally, allowing you to skip over the CAB portion of the cycle of care. There's no need for chest compressions, opening an airway, or breathing for the patient. Keep the patient still. Do not move the patient unless you or the patient's safety is compromised. Put on barriers if immediately at hand. However, don't delay emergency care if barriers are absent. Next, check for serious bleeding, shock, and spinal injury. As you move through the cycle of care, alert the emergency medical service if you find any serious medical condition. Now let's look at the primary assessment with an unresponsive patient. An unresponsive patient is one who is either completely unconscious or one who may be partially conscious but incapable of response. Begin again by assessing the scene. Stop, think, and then act. Make sure it is safe to help the patient. Next, give the responder statement. Hello, my name is, your name. I'm an emergency responder. May I help you? This patient doesn't respond to your statement, so tap him on the collarbone to further check responsiveness. While tapping the patient, ask, "Are you okay? Are you okay?" After delivering the responder statement, quickly check for an open airway and normal breathing. If you are unsure if the patient's airway is open or if he is breathing normally, quickly open the patient's airway using the head tilt chin lift. To perform a head tilt chin lift, first place your hand on his forehead. Next, place your fingertips under the point of his chin, like this. Finally, gently tilt his head back and lift his chin. Another method of opening an airway is the pistol grip, like this. When the patient's airway is open, check for normal breathing. To do this, look for chest movement and listen for breathing sounds. Also, with your ear next to his mouth, feel for expired air on your cheek. This check for normal breathing must be accomplished quickly. If the patient is not breathing normally, he needs CPR immediately. Avoid long delays. If the patient is not responsive or breathing normally, ask a bystander to call EMS and secure an AED if possible. If you are alone, use your mobile phone to call EMS. If you do not have a mobile phone, leave the patient to call EMS if no other option exists. This is the call first approach to emergency care. You call first to activate emergency medical services, then you provide assistance. This unresponsive patient is breathing normally, so continue your primary assessment by checking for serious bleeding, shock, and spinal injury. If a spinal injury is suspected, keep the patient's head, neck, and spine immobilized and do not move the patient. If no spinal injury is found or suspected, and you may need to leave the patient, place him in the recovery position. The recovery position allows the patient to breathe easier since there is little pressure on the chest. It also decreases the risk of something blocking his airway and allows fluids to drain should he vomit. To put an unresponsive breathing patient in a recovery position, first position the patient's arms like this. Next, grab the patient's far leg just above the knee and pull it up, keeping the foot on the ground, like this. Now, gently pull the patient towards you, putting him on his side. Once on his side, place the patient's lower hand near or under the neck for stabilization. If need be, gently pull back on the patient's head to assure an open airway. If the patient has to be kept in the recovery position for more than 30 minutes, consider turning the patient to the opposite side to relieve pressure on the lower arm. When a patient stops breathing normally and his heart is beating erratically or not at all, you can substitute manual chest compressions for the heart's normal pumping action to circulate blood through the body. The blood you push through the patient's body will carry some oxygen to important organs. Your willingness to respond may increase the patient's chance for survival until emergency medical service personnel arrive. CPR is a two-step process. Step 1, chest compressions, followed by Step 2, rescue breathing. In this skill, you'll learn how to perform chest compressions. If you are unable or feel uncomfortable giving a patient the rescue breaths, relax. Give the patient immediate and continuous chest compressions. Chest compressions alone are very beneficial to an unresponsive patient who is not breathing normally. Your efforts will still help circulate blood that contains oxygen. Begin, as usual, by assessing the scene for safety. Next, check the patient for unresponsiveness by giving the responder statement.
Hello, my name is Penny.
If there is no response to your statement, then tap the patient on the collarbone and ask, "Are you okay? Are you okay?" After delivering the responder statement, quickly check for an open airway and normal breathing. Here's an important note about normal breathing. In the first few minutes after cardiac arrest, a patient may be barely breathing or taking infrequent, noisy gasps. This is often termed agonal breathing. and these gasps must not be confused with normal breathing. Many patients in cardiac arrest make these gasping sounds. If the patient is not responsive or breathing normally, ask a bystander to call EMS and secure an AED if possible. If you are alone, use your mobile phone to call EMS. If you do not have a mobile phone, leave the patient to call EMS if no other option exists. This is the call first approach to emergency care. You call first to activate emergency medical services, then you provide assistance.
1, 2, 3, 4, 5,
Now, position the patient on his back if not already in this position. If necessary, expose the patient's chest. Find the compression site by putting the heel of one hand in the chest center. On some individuals, this position is between the nipples. Place your other hand on top of the hand already on the chest and interlock your fingers. Use the palm of your hand on the compression site. Keep your fingers off the patient's chest. Next, position yourself so that your shoulders are directly over your hands and your arms are straight. Lock your elbows, like this. Now deliver the chest compressions. Keep the force of the compression straight down and avoid pushing on the rib cage or the lower tip of the breastbone. Allow your body weight to deliver the compressions. To provide effective chest compressions, you should push hard and push fast, depressing the breastbone approximately 1/3 the depth of the patient's chest, at least 5 centimeters, 2 inches. After each chest compression, release, allowing the chest to return to its normal position. Repeat at a pace of 1, 2, 3, 4, and so on for 30 chest compressions. Perform the compressions as fluidly as possible. Your rate should be at least 100 compressions per minute. The rate is a lot faster than most people think. Push hard and push fast. With your instructor, you will practice chest compressions using a CPR mannequin. Do not perform chest compressions on someone who does not need CPR. As you've learned, chest compressions alone are very beneficial to a patient who is unresponsive and not breathing normally. However, if you are also willing to provide rescue breaths to a patient in need, you may further increase the patient's chance for survival until emergency medical service personnel arrive. After completing this skill, you should trust your training and provide an unresponsive patient who is not breathing normally with complete CPR, chest compressions, and rescue breathing. As always, begin by assessing the scene and give your responder statement.
Hello, my name is Juanita. I'm an emergency responder. May I help you?
Next, tap the patient on his collarbone and ask,
Are you okay? Are you okay?
After you deliver your responder statement, quickly open the patient's airway and check for normal breathing. If the patient is not responsive or breathing normally, ask a bystander to call EMS and secure an AED if possible. If you are alone, use your mobile phone to call EMS. If you do not have a mobile phone, leave the patient to call EMS if no other option exists. This is the call first approach to emergency care. You call first to activate emergency medical services, then you provide assistance. As in the previous skill, find the compression site by putting the heel of one hand in the chest center. On some individuals, this position is between the nipples. Place your other hand on top of the hand already on the chest and interlock your fingers, like this. Now, position yourself so that your shoulders are directly over your hands and your arms are straight. Lock your elbows. Now deliver the chest compressions. Keep the force of the compressions straight down and avoid pushing on the rib cage or the lower tip of the breastbone. Allow your body weight to deliver the compressions. To provide effective chest compressions, you should push hard and push fast, depressing the breastbone approximately 1/3 the depth of the patient's chest, at least 5 centimeters, 2 inches. After each chest compression, release, allowing the chest to return to its normal position. Repeat at a pace of 1, 2, 3, 4, and so on for 30 chest compressions. Perform the compressions as fluidly as possible. Your rate should be at least 100 compressions per minute. The rate is a lot faster than most people think. Push hard and push fast. After delivering 30 chest compressions, quickly position a ventilation barrier on the patient and open the patient's airway. To open the patient's airway, you will use the head tilt chin lift. First, place your hand on the patient's forehead. Next, apply firm backward pressure with the palm of your hand, tilting the head back, like this. Place the fingers of your other hand under the bony part of one side of the lower jaw near the chin. Avoid pushing directly under the chin. Lift the jaw upward to bring the chin forward. This immediately opens the airway. Now, with the patient's head tilted back and the ventilation barrier in place, begin your rescue breaths by pinching his nose closed. Give 2 rescue breaths, with each lasting about 1 second. Provide the patient with just enough air to make the patient's chest rise. Look for this rise in the patient's chest. If you can't make the patient's chest rise with the first breath, repeat the head tilt chin lift to reopen the airway before attempting another breath. Improper position of the head tilt chin lift is the most common cause for not being able to inflate a patient's lungs. Do not try more than 2 rescue breaths to make the chest rise. Minimize delay between chest compressions. After 2 breaths, whether they make the chest rise or not, begin chest compressions again. After delivering 2 rescue breaths, immediately begin another cycle of 30 compressions. Continue alternating 30 compressions with 2 breaths until emergency medical service personnel arrive. You can defibrillate using an automated external defibrillator. The patient becomes responsive and begins to breathe normally. Another emergency responder arrives and takes over your CPR efforts. Or lastly, you are too exhausted to continue. If more than 1 emergency responder is present, consider alternating care. To avoid fatigue, each provider can deliver CPR for 2 minutes and then switch. While switching providers, minimize chest compression interruptions. At this point during your training, your instructor may introduce you to the use of an automated external defibrillator, or AED. As you just learned, CPR is an emergency measure that can extend the window during which it may be possible to restart the heart. During this window of opportunity, you want emergency medical services personnel to be on their way to your location. This is why it's important to first call emergency medical services when a patient is unresponsive and not breathing normally. Qualified personnel can provide advanced cardiac life support to the patient. They can help the patient with drugs, artificial airways, ventilation devices, and defibrillation. Defibrillation is the process of restarting an erratic heart. Natural electrical impulses control your heartbeat. When these impulses fail, the heart beats erratically and no longer pumps blood. This is called fibrillation or twitching. Defibrillation administers a shock that momentarily disrupts the erratic signals and allows the normal heartbeat to return. As time passes, the probability of defibrillation restoring the heartbeat goes down. The benefit of prompt defibrillation was the reason for the development of easy-to-use automated external defibrillators, or AEDs. With AEDs, you no longer have to wait for emergency medical services personnel to defibrillate a patient's heart. AEDs can be used by lay rescuers like you. An AED is a portable machine that automatically delivers a shock to a patient who is not breathing normally and whose heart has stopped beating or is beating irregularly. All AEDs function in the same basic way. First, you turn the AED on by either opening the unit or pushing the appropriate button. Next, connect the AED to a patient via 2 chest pads. When the AED is turned on, its computer analyzes the patient's need for a shock. If the AED detects a heart rhythm in need of a shock, the machine will indicate that a shock is advised. Depending on the type of machine, either the emergency responder shocks the patient or the machine does so automatically. To effectively treat heart fibrillation, you must be able to rapidly integrate CPR with the use of an AED. To give a patient the best chance of survival, 3 actions must occur within the first moments of a cardiac arrest. First, Activate the emergency medical services system. Second, provide immediate CPR. And third, use an AED. These three actions are all part of the chain of survival. If a bystander is available while you provide the patient with CPR, have them call emergency medical services and retrieve an AED. Further, bystanders can set up the AED and apply the chest pads while you continue CPR. Overall, both of these bystander actions allow you to minimize interruptions in CPR.
What happened?
Greg cut himself on the saw. Can you call for help and wait outside for them till they get here and bring him back?
Okay.
Thanks.
Can I help with anything?
Yeah, could you get the first aid kit, please? Yeah. Thank you. Okay, Greg, try and elevate him here. Okay, try and keep your arm elevated here. Great, thanks. Great. Continue Mary. Thanks. Okay, Greg. This on here. Greg. Okay, let's have a look at this.
Control of bleeding is a basic but important first aid skill. By controlling a patient's serious bleeding, you can positively influence a patient's outcome. Serious bleeding is life-threatening because blood carries oxygen to the body tissues. The body holds about 6 liters or quarts of blood, and losing even one can cause death. There are 3 types of bleeding depending on the type of blood vessel injured. Arteries are the largest vessel and carry blood from the heart to the tissues. Arterial blood is bright red and spurts with each heartbeat. Arterial bleeding is the most serious because the patient can lose a lot of blood quickly. If a major artery is cut, death can occur in 1 minute if not treated. Activate the emergency medical service immediately for this type of bleeding. Veins lead from the tissues back to the heart. Venous blood is dark red and flows steadily without spurts. Venous bleeding can also be life-threatening. If you cannot control it, contact the emergency medical service and monitor the patient's cycle of care. Capillaries are tiny blood vessels between the arteries and veins where the blood and tissues exchange oxygen. Capillary bleeding tends to be slow and easily controlled unless the injury covers a large area. Monitor the patient's cycle of care and contact the emergency medical service if necessary. To begin helping a patient with serious bleeding, first assess the scene to make sure it's safe for you to approach. Put on appropriate barriers and deliver your responder statement, asking the patient if you can help. If the patient says yes, call emergency medical services. Reassure the patient as you treat for bleeding, and if needed, assist the patient into a position of comfort while treating. Since the patient is responsive and breathing normally, you can sidestep CPR, chest compressions, opening an airway, and breathing for the patient. With a responsive patient, proceed immediately to the S in ABCABS on the cycle of care. The first S in ABCABS prompts you to check for serious bleeding. To control serious bleeding, use sustained direct pressure. Put a clean cloth or dressing on the wound and apply constant pressure. If you have no dressing, use a piece of cloth or even just your gloved hand if there's nothing available. Maintain the pressure continuously, but you may periodically release pressure to see if the bleeding has slowed or stopped. In addition to sustained direct pressure, you may also use a pressure bandage. While maintaining direct pressure, tie another dressing over the initial one. The patient may assist if able. If the dressing becomes blood-soaked, don't remove it. Instead, add another on top and continue direct pressure. Applying sustained direct pressure and pressure bandages best controls bleeding. However, there may be regional treatment variations, such as elevating bleeding limbs, giving the patient oxygen, and applying a tourniquet as a last resort to controlling serious bleeding. Your instructor will advise you of these variations. Shock is the body's response to serious injury or illness. Shock can be life-threatening and happens when not enough oxygenated blood reaches the body tissues. This occurs due to serious bleeding or when the body no longer regulates blood flow to the tissues. In general, always treat an injured or ill patient for shock, even if the signs and symptoms for shock are absent. There are 9 indications of shock, though some occur with other injuries. They are rapid, weak pulse, pale or bluish tissue, moist, clammy skin, possibly with shivering, mental confusion, anxiety, restlessness or irritability, altered consciousness, nausea and perhaps vomiting, lackluster eyes, dazed look, and shallow but rapid labored breathing. By the time you get to shock management, you will have progressed well along the cycle of care. You will have assessed the scene and applied your barriers. Through primary assessment, you would have confirmed the patient's level of responsiveness and that he is breathing normally. Since the patient is breathing normally, there is no need for CPR. If the patient is unresponsive or bleeding, you would have already alerted the emergency medical service. If he were bleeding, you would have treated him by applying direct pressure. To treat a responsive patient in shock, let the patient determine what position is most comfortable, sitting or lying down. To treat an injured and unresponsive patient, do so in the position you find him. If there may be a head, back, or neck injury, don't move the patient and keep his head and neck immobile. More on spinal injury treatment in the next skill. Regardless of whether the patient is responsive or unresponsive, to treat for shock, maintain the patient's body temperature based on the local climate. This may mean covering the patient with a blanket or exposure protection from the sun. If there's no reason to suspect spinal injuries or leg fractures, elevate the patient's legs 15 to 30 centimeters, 6 to 12 inches. This shifts blood to the more critical chest and head areas. Spinal cord injuries can cause permanent paralysis or death. The spinal cord runs through the neck, down the back, and connects the brain to the rest of the body's nervous system. A break in the spinal cord makes it difficult for the brain to control the nervous system below the break. Injuries to the head, neck, or spine may injure or threaten the spinal cord. Moving a patient with a head, neck, or spine injury may make the injuries worse. Therefore, never move a patient with a suspected spinal injury unless absolutely necessary because of imminent danger. With a responsive patient, conduct your primary assessment where you find him. You would only move the patient to avoid immediate further harm, such as if the patient were in the water or a burning car or building.
Take it easy, okay?
You would also move the patient if necessary to provide CPR. You should suspect spinal injury with situations that cause injury to the head, neck, or spine. These include auto accidents, being thrown from a moving object, falling, especially from a height higher than the victim, a penetration wound such as a gunshot, any severe blow to the head, neck, or back, an accident that includes hitting something head first, such as diving into shallow water, lightning strike, or any severe impact injury regardless of what part of the body was struck. 8 indications that a patient may have a spinal injury are change of consciousness, difficulty breathing, vision problems, inability to move some or all of the body, paralysis, headache, vomiting, loss of balance, tingling or numbness in the extremities. For an unresponsive patient, start by assessing the scene for danger. Put on appropriate barriers if available, and begin to conduct your primary assessment. Conduct your assessment with the patient in the position you find her. Unless the patient's safety is in question, she might need CPR, or you need to control serious bleeding of a wound you can't see. Deliver your responder statement and have someone call emergency medical services.
Call for help.
The patient must be on her back for continued care. If she's not already on her back, you'll have to turn her while minimizing risk to her spinal cord. You want to stabilize the head and neck so that as you turn the patient, they stay aligned and unmoved relative to the spinal column. If you have someone who can help, have him hold and stabilize the head as you roll the patient all at once, keeping the head, neck, and spine together as a unit. If you're alone, you'll stabilize the head yourself. The log roll technique helps you do this. Tuck the arm away from you under her hip, and while supporting her head, roll the patient toward you. Gently ease the patient onto her back and continue with the cycle of care by starting CPR if the patient isn't breathing normally. If the patient is breathing normally, check and treat for serious bleeding, shock, and spinal injury. In a primary assessment, you've learned how to apply the cycle of care to ask 2 initial questions when someone is in need of emergency assistance. Is the patient's airway open, and is he breathing normally? When a responsive and conscious patient is choking, they neither have an open airway nor are they breathing normally. A choking patient needs immediate help to restore breathing. In adults, the most common cause of choking is food. Let's learn how to help a conscious and unconscious patient expel an object that's causing him to choke. If you believe a person is choking, begin with scene assessment. Stop, think, and act. Since you're not likely to have contact with body fluids and time is important, you usually do not need personal protective barriers. Ask a responsive patient,
Are you choking?
if the patient is coughing, wheezing, or can speak, encourage the patient to cough until he expels the object. If the patient cannot speak or breathe, give the responder statement and alert emergency medical
I'm an
services.
emergency responder. May I help you? All right, take it easy.
After the patient indicates he wants your help, a nod will do. You may use back blows, abdominal thrusts, or chest thrusts to attempt to dislodge the object. Techniques for handling a conscious choking patient vary internationally. Your emergency first response instructor will teach you the techniques appropriate for your area, and it's those you should use when assisting a choking patient. In general, however, there is no clear evidence that one technique is better than another, but there is evidence that if one technique does not help a choking patient, then another one might. To deliver back blows, take a position to the side and slightly behind the patient. Supporting the chest with one hand, lean the patient forward. Next, firmly strike the person between the shoulder blades with the heel of the other hand 5 times. Stop if the obstruction clears or move on to another technique. Abdominal thrusts use residual air in the patient's lungs to blow the obstruction clear. Stand behind the patient with your arms around her waist. Find the patient's navel with one hand. Make the other into a fist and place the thumb side against the patient's abdomen slightly above her navel, like this. Put your other hand on top of your fist. Bowing your arms so you don't squeeze the patient's ribs, pull your hands inward and upward in a thrusting motion. Stop if the obstruction clears or move on to another technique. Abdominal thrusts may not be possible with some individuals, such as those who are pregnant or markedly obese. In these cases, provide thrusts in the center of the chest. Use your fist with the thumb inward and the other hand on top, just as you do with abdominal thrusts, but put your fist on the same site where you would perform a CPR compression. Continue using one or more of these techniques until the obstruction is relieved or the patient becomes unconscious. When you practice these techniques, be sure to simulate thrusting. Never perform thrusts on a person who does not have an obstructed airway. If a responsive, choking patient becomes unconscious while you are trying to help, carefully help the unconscious patient to the ground. Next, activate emergency medical services and immediately begin CPR, chest compressions. The compressions should dislodge any obstruction. Following the chest compressions, you should quickly look inside the patient's mouth to see if there is any solid material visible in the airway. If an object is seen, you should remove the object with your finger. If no object is seen or the object has been removed, you should proceed with 2 rescue breaths. Finally, continue to give 30 compressions followed by attempting 2 rescue breaths, just as you've already learned. Continue CPR until the obstruction is relieved and the patient becomes responsive or emergency medical services arrives. Depending on local guidelines, restrictions, or laws, your emergency first response instructor may be able to offer a skill development session on emergency oxygen use. Receiving adequate oxygen is crucial, especially after a serious injury or illness, near drowning and scuba diving incident, plus continued exposure to altitude. You can decrease patient stress and support the respiratory system by administering emergency oxygen. You may want to seek additional and more advanced oxygen training if you are a scuba diver or you frequent locations that offer aquatic activities. Now that you understand the 9 primary care skills, let's apply them to some realistic situations. Watch as the emergency responder in each scenario adapts the cycle of care to the realities of the situation.
Grandma, are you okay? What happened? What's wrong? What happened? Hang on,
Stop,
everything's gonna be okay.
think, and then act. Is there a hazard here? The emergency responder sniffs for gas and confirms the gas stove is turned off. The caregiver delivers the responder statement and gets emergency care on the way.
Do you need help? It's okay, I'm an emergency responder. May I help you? Jimmy, come here quick. It's okay. What's wrong? I don't know. Something's wrong with Grandma. Go call for help. Tell them we have an emergency and then come back and tell me what they say.
I'll call and come back.
It's okay, Grandma.
The emergency responder monitors the patient and uses the cycle of care to guide her. She's responsive and breathing, so there's no need to provide CPR. Further, there's no evidence of bleeding.
Help will be here soon.
Help me put her in the recovery position. Put her leg a little bit forward. Go get the pillow and blanket on the couch. Go wait for the ambulance outside.
The emergency responder treats for shock and continues to monitor the patient until help arrives.
Be okay. Help is on the way.
The emergency responder stops, assesses the scene, thinks, and then acts.
Hey, this is Fabio, an emergency responder. May I help you? May I help you? Are you okay? Are you okay?
The emergency responder finds the patient unresponsive. His airway is open, but he is not breathing normally.
Hey, Sherilyn. This is Fabio. Listen, I'm in room 3. RF is down. He's unresponsive and he's not breathing. I want you to activate the company emergency plan. Then I want you to call emergency services and direct him here to room 3.
Using the cycle of care to guide him, he calls emergency medical services and immediately begins chest compressions.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 5, 6, 7, 28, 29, 30.
The emergency responder provides CPR until emergency medical personnel arrive.
One, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17.
A medical emergency with more than one patient and only one emergency responder requires some thought. You can only do so much, so do the best you can. Stop, think, and then act.
Yeah, I need to report an auto accident on the corner of Alton and Pacific. It looks like you might have a couple injured passengers. Yeah. Yeah, okay. Sit tight, all right? Help's on the way.
The emergency responder approaches the scene cautiously, keeping himself safe and watching for hazards as he approaches the scene.
Hey, my name's Matt. I'm an emergency responder. May I help you?
Yes.
Well, where do you hurt?
On my head. I'm okay.
Okay, I want you to try not to move it, okay? Let's wait till the medical crew gets here so they can check you out. All right? It looks like your passenger may need some help, so I'm gonna go take a look at her. So just sit tight and relax, all right? Okay. I'll be nearby. All right. Hey, how you doing? You okay? You all right? Just relax, okay?
The emergency responder uses the cycle of care to guide him and begins to treat this patient's serious bleeding. Notice that he continues to monitor the patient while maintaining continuous direct pressure on the wound.
How's your head feel?
The same.
Okay,
The
just relax.
emergency
Help's on its
responder
way.
asks this question of the first patient as a simple way of checking to see if he is still responsive and breathing.
Is there anything that I can do?
Are you a trained emergency responder?
No.
That's okay. You know what? You can put on this extra pair of gloves I have here.
Okay.
Try and lay still, okay? Keep your head still for me. What I need you to do is I need you to put pressure on this wound here, okay? If you need another bandage, go ahead and take one out of that box and put it right on top of this, all right? Keep pressure on the wound the whole time. Okay, so when I take my hands off, go ahead and replace them with yours, okay? Here we go. Good.
The emergency responder continues to use the cycle of care to guide him and monitor both patients until the emergency medical service providers arrive.
There you go, lay still. Okay, keep pressure on there.
Okay.
Okay, try and relax, okay? I'm gonna hold your head until the ambulance gets here.
All right.
Sit tight, all right? The guys are here.
How many people do we have in the vehicle? One?
Just two.
Two, that's it? Anyone ejected? Anyone else in the vehicle? No?
Came on these guys.
No, that's it. Okay, what do you have right there?
As you saw, having more than one person at the scene increases the aid available. By encouraging your family and friends to complete the emergency first response courses, you increase the chances there will be more than one emergency responder at hand in a medical emergency. As an emergency responder, you play a crucial role in a medical emergency. In life-threatening emergencies, you provide the critical first links in the chain of survival that summons emergency medical aid and monitors the patient's lifeline, providing aid that increases the chances of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability. Most emergency responders will never need their skill, but practicing them and reviewing this program will help you be ready to reach out and help another in need should you ever need to. Now that you've completed Emergency First Response Primary Care, you're ready to complete the Secondary Care course. As you recall, this is secondary care because it follows the primary care of assuring that all life-threatening injuries and illnesses are attended to in priority order according to the cycle of care. And, as you recall, primary care never stops. You constantly monitor the patient using ABCABs and the cycle of care to guide you. However, if emergency medical services are either delayed or unavailable, you'll need the following secondary care skills. You'll practice 4 secondary skills: injury assessment, illness assessment, bandaging, and splinting for dislocations and fractures.
No. Go back here. Nothing?
Injury assessment helps you identify injuries that affect the patient. You can attend to some of the injuries and you will report them to emergency medical personnel once they arrive. Remember that you always begin with primary care using ABCABs and the cycle of care to guide you. Assess the scene. Stop, think, and then act. Apply your barriers if readily available. Give your responder statement while checking to see if their airway is open and noting if she's breathing normally. Contact the local emergency medical service if at any time you begin providing primary care or you feel that you will need assistance.
Let's call for some help.
Be sure that you attend to any primary care issues before beginning a secondary injury assessment. Start by telling the patient that you're going to check for injuries. Hold the patient's head and ask the patient to keep her head still and answer questions verbally rather than nodding or shaking her head. It helps to ask questions that she can't answer with a yes or no. You start your assessment at the head and work to the patient's toes. If the patient complains of head, neck, or back pain, stop the assessment immediately and keep the patient immobile until help arrives. Feel for deformities on the patient's face with a gentle touch. Check the ears and nose for blood or fluid. See if the patient's pupils are the same size and have her follow your finger with her eyes without moving her head or neck. Check the eyes for smooth tracking. The eyes should track together. Also, check pupil size. Feel the skull and neck for abnormalities. If the patient complains or you find something, stop the assessment. Slide your hands over the shoulder blades and gently push against the back. Press inward on the shoulders and run your fingers over the collarbones to the center. As you perform these steps, you're looking for irregularities or blood, or for the patient to mention pain or other unusual sensations caused by your touch. Stabilize the patient's arm with a hand on the shoulder and slide your hand gently down the upper arm, elbow, and wrist. Repeat on the other arm. Ask the patient to wiggle her fingers on both hands and squeeze yours to check for paralysis or weakness. Inspect the chest for deformity. Place a hand, palm in, on each side of the patient's rib cage and gently push inwards. Gently put your hands under the patient to check the spinal column. Cover as much area as possible without moving her. If you find any irregularities, stop the assessment. Ask the patient to tell you if she feels pain. Gently push on the patient's abdomen on the right, left, and above and below the navel. Move hands gently over the hip bones to check for swelling or hardening, tissue softness, unusual masses, joint tenderness, and deformities. Avoid pushing inward on hips. Ask the patient to wiggle her toes and press her foot against your hand. Repeat this with the other leg. After your assessment, you will attend to the injuries you can. Otherwise, continue to monitor the patient using the cycle of care to guide you, and report what you found during the assessment to emergency medical services personnel. Illness assessment helps you find and report medical problems that affect the patient's health and may aid with treatment. You'll assess the patient by asking questions and by checking the patient's breathing, pulse, temperature, and skin. In class with your instructor, you'll practice an illness assessment on a healthy person. Assessing a healthy person may help you recognize differences later if you assist an unhealthy person. As you've learned, you start with primary assessment. After giving the responder statement and assuring that the patient is responsive and breathing normally, get something to write on so you or someone assisting you can record what you find. There is an illness assessment record sheet in your participant manual. To help you remember how to begin an illness assessment, use the mnemonic SAMPLE. The S in SAMPLE stands for signs and symptoms. A stands for allergies. M stands for medications. P stands for pre-existing medical history. L stands for last meal. And E stands for events. The S stands for signs and symptoms. Signs are something you, the rescuer, sees. Symptoms are something the patient tells you he's feeling. Ask the patient how he feels and what happened right before getting ill. Ask, how do you feel now? Next, you'll check the patient's pulse. Find the pulse on the patient's wrist. Feel the pulse with your fingers, not your thumb, and count for 30 seconds, then multiply by 2. The typical adult pulse rate at rest is 60 to 80 beats per minute. Next, you'll check the patient's respiration. As you do this, remember the typical adult breathing rate at rest is 12 to 20 breaths per minute. Someone breathing markedly faster or slower may have a medical problem. To check the breathing rate, watch the patient's chest or place a hand on it while timing for 30 seconds, then multiplying by 2. Attempt to check a patient's respirations without them knowing you are doing so. Listen for wheezing, gurgling, or high-pitched noises. Note if the patient complains of short breath, dizziness, lightheadedness, chest pain, or numbness, or tingling in the arms or legs. Next, check the patient's temperature and moisture. Feel the patient's forehead with the back of your hand. See if it's warm, hot, cool, moist, clammy, etc. Check the patient's color. Is it pale, ashen, reddish, bluish, or yellowish? Does it have blotches? If the patient has dark skin, check for color change in the nail beds, lips, gums, tongue, palms, whites of the eyes, and earlobes. Usually, an adult at rest should have skin that's warm and dry to the touch. Noticeable changes in temperature, moisture, and color may indicate problems. Next, check the patient's eye pupils. Are they enlarged? Small? Unequal? Any of these may indicate problems. Also in the mnemonic SAMPLE, the A stands for allergies. Ask the patient about allergies to medications, insects, food, or the like. Ask the patient, have you been exposed to something you are allergic to? While talking to the patient, look for medic alert bracelets. Has the patient been bitten or stung by an organism? If so, and the allergic reaction is severe, treat the severe allergic reaction as a medical emergency and follow primary care procedures. A severe allergic reaction, anaphylaxis, can be treated by epinephrine. People who have suffered a prior episode of anaphylaxis often have prescribed an autoinjector of epinephrine. Have the patient use the autoinjector or assist them with its use. Next, the M stands for medications. Ask the patient if he takes any medications. If so, ask, what medication do you take? Did you take it today? How much did you take and when? If possible, get the patient's medication so you can turn it over to emergency medical personnel when they arrive. The P in sample stands for pre-existing medical history. Ask the patient if he has any medical conditions like asthma, epilepsy, heart conditions, or diabetes. The L in sample stands for last meal. Ask the patient, when did you last eat? What did you eat?
And any other events that you could think of that led up to this?
The E in sample stands for events. Ask the patient about or note the events that led up to the illness. Bandaging helps control bleeding, immobilize the injury, and reduce dirt or other contaminants from entering a wound. It's a skill that can range from life-saving in the case of serious bleeding to simply helping the patient feel more comfortable. After attending to primary care and injury assessment, you may apply roller bandages directly over a sterile dressing on a wound. As you recall, once you have a dressing in place, you don't remove it. Start below the wound and wrap upward over it. Wrap tightly enough to hold the bandage snugly in place, but loose enough that it doesn't restrict circulation. Leave fingers and toes exposed so you can check them for proper circulation. If you're bandaging a foot, start with a couple of turns around the ankle, then over the injury site on the foot. Similarly, start a hand bandage around the thumb and wrist. Elbow and knee injuries normally call for wrapping above and below the joint to stabilize the injury. Triangle bandages support injuries to the arm, ribs, or shoulder. Start with the bandage top over the shoulder on the affected side. Bring the arm over the bandage, then bring the low end of the bandage up behind the neck and tie it off. Support the arm and hand with the fingers showing. If you suspect broken ribs, tie a second bandage to hold the arm against the injury side of the chest. This helps immobilize the entire affected side of the torso. The pressure immobilization bandage is a treatment for snake bites and a specific list of injected venoms by other animals. Other than snake bites, check with local medical authorities prior to using this bandage for other envenomations. Ideally, select a broad elastic bandage if available. You may improvise by using any flexible material such as clothing or towels that could be torn into strips of at least 7 centimeters, 3 inches long. All bandages should be applied as firmly as you would apply a bandage to a sprained ankle or wrist. Apply the bandage as soon as possible after a bite. Also, avoid taking off clothing and having the patient move. If the bite is not on a limb, simply apply firm direct pressure on the bite site. If the bite is on a limb, begin bandaging at the fingers or toes and continue upwards as far as possible and including the bite site. This method of immobilization bandaging restricts bodily fluids from flowing into the limb, reducing the spread of venom. By adding a splint, you further reduce joint and limb movement and venom flow. Bind the splint to the limb using more of your bandage, like this. Once on, do not remove bandages or splints. Seek medical attention as soon as possible. Splinting immobilizes broken bones and dislocations. This reduces the risk of further injury and serious bleeding and lessens the pain for the patient. You may need to apply a splint if emergency medical care is either delayed or unavailable. When needed, splinting follows all primary care concerns, injury assessment, and any necessary bandaging. Splint the injury in the position you find it. Don't try to straighten it. and try to minimize moving the affected limb before you splint it. You can use a commercial splint or improvise with almost anything rigid. Choose a splint long enough to immobilize joints above and below the injury. Pad the splint with extra padding inside body curves and hollows for even, comfortable contact with the splint. Bandage the splint in place using a roller bandage, adhesive tape, or other material available. It should be snug enough to immobilize the injury, but not restrict circulation. Check the pulse before and after splinting for blood flow. Gently squeeze the patient's fingertips or toes and check that the nail beds immediately regain their color. If not, or there's no pulse, loosen the bandages so normal circulation returns. If the fracture involves an arm, you can put the arm in a triangle bandage after splinting. One important point: do not splint if doing so increases patient discomfort or pain. Now that you understand the 4 secondary emergency first response skills, let's apply them to some realistic situations. Note in each scenario that the emergency responder first attends to any primary care issues using ABCABS and the cycle of care to guide him. Second, he confirms that EMS is either delayed or unavailable before moving into secondary skills. The emergency responder takes a moment to assess the scene. He stops, thinks, and then acts.
Hey there. Looks like you took a little spill. My name's Pat Jones. I'm an emergency responder. May I help you?
Yeah, I think I broke my arm.
Yeah, anything else hurt here?
Because the patient is responsive and talking, the emergency responder knows that the patient has an open airway and is breathing normally.
Okay, just relax and try not to move, okay? While I try and get help.
Okay.
No service. Guess I won't be able to get emergency medical services here, but it's okay. I can assist you. Try not to move your head at all.
Okay, all right.
Let me take off your glasses, okay? You doing okay?
Yeah.
All right, open your eyes and try not to move your head while you look at my finger. Perfect. Let me check your ears for you. How's your head feel?
It feels good.
Any pain when I'm feeling this?
No.
What about back here? Nothing?
That's fine, that's fine.
Okay, how do your shoulders feel?
I feel okay.
Okay. Any pain?
No.
Nothing?
No.
Okay, how you doing, okay?
Okay.
Don't move your head. How's that feel?
That's okay.
I'm gonna check your spine for you, okay? Tell me if you have any signs of pain. Anything?
No.
Okay. And check your abdomen now. Does that hurt?
No.
Here?
No.
Here?
That's okay.
Here?
It's good.
Okay, I'm gonna check your hips. How's that feel?
It's okay.
All right, I'm gonna go down to your legs now. Feel any pain here?
No.
Anything?
No.
Wiggle your toes for me. Okay, let's do the other side. How's that feel?
Feels good.
Can you wiggle your toes for me? Okay, which arm hurts?
It's my right arm.
Okay, I'm gonna leave that alone for now, and I'm gonna bandage this cut first. Then I'm gonna splint your other arm, okay? That should make you more comfortable, all right?
Okay.
Let me get the splint, I'll be right back. I got a blanket for your head, okay? Let's move this out of the way. I'm gonna easily move up your head. Okay, lift it up slightly. Okay, set it down. How's that feel?
That's okay. It's good.
Okay.
It's good.
Let me see. Let me see this arm. Try not to move your head, okay?
All right.
All right. So what were you doing out this morning? Just going for a bike ride?
Yeah.
Yeah? What'd you do, hit a rock, didn't see it or something?
I don't know.
Yeah. This should make you feel a bit better, okay, buddy? What's your name?
Eric.
Yeah? How you feeling?
It's just my arm, man.
Yeah. Looks like you took a little bad spill on that side. I'll get to it in just a second, okay? Doing okay?
Yeah.
All right. Just about done here. Okay, I'm gonna splint your arm now, okay? You help by moving your wrist area, and I'm gonna move your elbow up, and I'm gonna slide the splint underneath your arm, okay? At the count of 3. 1, 2, 3. I know it hurts. This will make it feel more comfortable. Good. Let's move it across your chest slightly. Okay, I'm gonna tie the splint now, okay? You doing okay?
Yeah, yeah.
All right, I know this hurts, but it will feel better. All right. Look, we're pretty far away from emergency medical services, okay? And I can't get any service down here. I can take you, or I could go get help. I think it'd be fastest if you come with me. Are you comfortable with that?
Carrie,
What?
are you okay?
Oh, hi, Marino. Just something I ate.
Well, you don't look well at all. Look, I'm an emergency responder. Can I help by taking your pulse and other things just in case?
Yeah, but it's really just lunch.
Let's see, well, what did you have for lunch?
The usual. Salad with dressing.
Well, your pulse is 110 and your respiration is 22. When did you start to feel ill?
About an hour ago.
And how do you feel now?
About the same.
Are you taking any medication?
Blood pressure stuff.
Have you taken any today?
I took it at lunch. I just started a new prescription.
Do you have the prescription with you?
Yeah.
Carrie, have you been doing any exercising in the last minutes before I came in?
No.
Well, your pulse is racing, you're breathing heavy, and you're cold and clammy. As a precaution, I think we should get you checked out.
I don't think it's anything.
I'm sure it's not, but just in case.
Okay.
Yes, can you call the emergency response team to Carrie Tull's office? Yes, he's feeling more than mildly ill. No, I'm okay here. Just make sure you bring them back here as soon as they arrive.
As an emergency responder, you play a crucial role in a medical emergency. Your primary care response skills are the critical first links in the chain of survival that summon emergency medical services and monitors the patient, providing aid that increases the chances of survival or revival. In emergencies that are not immediately life-threatening, you provide comfort and reduce the risk of permanent disability. Your emergency first response secondary care skills can benefit patients by alerting medical personnel to conditions that need attention, by reducing further injury, and by increasing patient comfort. As you've already learned, few emergency responders ever need their skills, but if you ever do, you'll be ready to reach out and help another in need.
Defibrillation is the process of restarting an erratic heart. Natural electrical impulses control the heartbeat. When these impulses fail, the heart beats erratically and no longer pumps blood. This is called twitching or fibrillation. Defibrillation administers a shock that momentarily disrupts the erratic signals, possibly allowing a normal heartbeat to return. The heart rarely resumes beating without defibrillation, even with CPR. As time passes, the probability of defibrillation restoring the heartbeat goes down. This is why, if you're alone and you witness the sudden collapse of a patient of any age, you contact the emergency medical service and get an AED if available before you begin providing care. The shorter the time between cardiac arrest and defibrillation, the better the patient's chances. The need for prompt defibrillation led to the development of automated external defibrillators, or AEDs. AEDs reduce the interval between loss of heartbeat and defibrillation because they make it possible for lay emergency responders to attempt defibrillation before EMS arrives.
Deliver shock now. Press shock delivered.
AEDs electronically monitor the need for and administer a shock. Because AEDs are automatic, they're not difficult to use. The steps you follow vary slightly, however, depending on whether you witness sudden cardiac arrest or whether you find the patient unresponsive.
Gordon, are you okay? We just started. Gordon?
If you witness a patient collapse from apparent sudden cardiac arrest and you have an AED immediately available, you begin by administering one shock with the AED. If you did not witness the patient collapse, or there will be a delay while someone retrieves the AED, you start with CPR as you've already learned. In either case, follow the ABCDs. Assess the scene, put on barriers, and alert EMS. Open the airway with the head tilt chin lift and check for breathing for at least 5 and no more than 10 seconds. If there is no breathing and you have no reason to suspect an obstructed airway, immediately deploy the AED if available. Otherwise, provide CPR until the AED arrives. Bare the patient's chest and attach the pads like this. Plug the pads into the AED and turn the unit on. Allow the AED to analyze the patient's heart rhythm. It will then either instruct you to deliver a shock if needed or do so automatically.
Shock advised. Charging. Deliver shock now. Press shock.
After the shock, the AED will analyze the patient and confirm the resumption of a heartbeat. If there is no heartbeat, start CPR beginning with chest compressions. After 5 cycles of 30 compressions and 2 breaths, look, listen, and feel for signs of breathing and circulation. If still absent, use the AED to deliver another shock. Continue to give single shocks and 5 cycles of 30 compressions and 2 breaths until the patient resumes breathing, until relieved by EMS personnel, or until you are physically unable to continue. There are a few special considerations when using an AED. If the person is wearing a transdermal medication patch where the AED pads go, remove the patch and wipe the skin dry before applying pads. Some patients have pacemakers or implanted defibrillators. You'll see where these are when you expose the chest. Avoid placing the AED pads over or near these devices. If the patient has an implanted defibrillator, wait for it to finish delivering shocks before attaching the AED pads at least 1 inch or 2.5 centimeters away from it. Because water and metal conduct electricity, use caution with a wet patient or a patient lying on a wet or metal surface. Dry a wet patient before applying the AED pads, and move a wet patient off of a wet or metal surface. If you cannot move the patient off a wet or metal surface, keep the AED pads out of contact with the surface. Warn others and get well clear of the patient to avoid receiving a shock. Cardiac arrest caused by severe trauma, such as severe car accidents, gunshot wounds, and falls from high places, may not respond to AED shocks. These patients will need care by EMS and a trauma center. Similarly, patients with hypothermia may also not respond to AED shocks. Provide CPR and breaths for these patients until emergency personnel arrive, but do not continue to provide shocks if they do not respond to the initial shock. When the patient is a child, use child CPR techniques with the same AED procedures you use for an adult. The AED pads, however, should ideally be for child use. If child pads are not available, use adult pads. AEDs vary in how you set them up for use with children, so look at the AED pads. Some AEDs have keys or settings for child use. Do not use child pads in child settings when attempting to defibrillate an adult.